Now it is really a tremendous honor for me to introduce the keynote speaker. I think one of the joys of academics that I've always had is you get to see people that you read their articles, you get to know them in print, and then one day you get to meet them, and they're even more impressive in person than they are actually on paper, and that's the way I've always felt about Dr. Manny Brown. Dr. Brown is a professor of radiology through Wayne State University, and we all know him as the chairman of radiology at Henry Ford Hospital, and he's also the president of the American College of Radiology. I met Dr. Brown years ago when he was at Pittsburgh, but before that he was at the Mayo Clinic and on faculty for 14 years. He achieved the rank of professor of radiology at the Mayo Medical School. He also concurrently served as the head of nuclear medicine in the Department of Radiology, and was also then became the division head and vice chair for the Department of Radiology at Pittsburgh, where I first met him about 15 years ago. Dr. Brown's been very active in organized medicine, including the American College of Radiology. He served on numerous ACR committees and commissions and was chair of the Nuclear Medicine Commission for 6 years. He served as the president of the American College of Radiology, as I alluded to, over the past year, and he's authored or co-authored over 150 articles in the peer-reviewed literature, as well as 49 book chapters. So with that as an introduction, I'd like to introduce Dr. Brown to give our keynote speak. Dr. Brown?
Thank you very much, Suresh, for the kind words and the years of friendship that we've had. Let me find my slides here. I will find my slides here. Again, thank you very much. I also want to thank Baron Shaw for inviting me. It's good to be back in Michigan. I've changed the title of the talk a little bit to Healthcare Reform and the ACR, not the future of the ACR, because I can tell you that the future of the ACR is excellent. And I really do appreciate Suresh's comments about the value of radiology, because my talk will focus on the challenges we will face and not so much the benefits that we have both enjoyed as practitioners and the benefits that we provide to our patients and our referring physicians. So the objectives of the talk are to discuss the latest healthcare reform issues affecting radiology, to identify, or you should at the end, 3 major ACR initiatives and advocacy, and identify 3 major ACR educational programs. But I don't have enough time to do that, and so the answer to the third one, so that you can say that you actually have it, the 3 of the major initiatives is the ACR Education Center, the American Institute of Radiologic Pathology, and the new iPad app, and case in point, and as a matter of fact, the ACR gives out more hours of CME than any other radiology organization except for the RSNA. So I've covered objective number 3. So healthcare reform is really the rubric used to describe policy changes and policy creations. And as you can see, it's to broaden the population that receives healthcare, expand the array of healthcare providers available, to improve access to various healthcare specialists, to improve the quality of health care, to give more care to citizens, and to decrease the cost of health care. And what we really will be talking about is what's going on to decrease the cost of health care, because that's really what's going to be affecting us all in the near future. So what's the problem? The problems facing health care is the unsustainable increase in health care costs, growing number of uninsured patients in our country, By one estimate, depends on what assumptions you use, the unfunded liabilities in Social Security and in Medicare is between $50 and $80 trillion and rising, and there is no way, under any circumstances, that that amount of money can be found in the current system, even given the best of circumstances. We have already seen $6 billion in imaging cuts from CMS since 2007, and more are proposed. There are strong forces in the government and in the insurance industry to work on ways of reducing the perceived problems of too many imaging tests. There continues to be economically motivated self-referral, which goes unchecked and adds to excess testing. CMS continues, and I'll go into this in a little more detail, outside of the ruck to attack both the professional and technical components of reimbursement with various means. Consumers now have high deductibles, and I'll talk a little bit about that. And so what's going to happen is we've already seen reductions in ambulatory and semi-elective surgeries, and that's going to affect radiology as well. There are major changes to our traditional models of radiology, and I won't go into a lot of detail on that, but there's more movement to subspecialization and requirements for 24/7 coverage. We will see disaggregation where the old models of a single small radiology group may not work, and new models will be developed using teleradiology. But unfettered teleradiology brings the threat of commoditization. And there's been an increase in the corporatization and disintermediation of radiology, where the interpretation goes to outsourced providers, or where radiologists become either hospital employees or become employed by corporations such as Imaging Advantage that have financial and or corporate ties with for-profit hospital chains. And we're also looking at new methods of healthcare financing, whether it's through ACOs, bundled payments. The old fee-for-service method is on its way out. So we must figure out our role, radiologists' role, in the reimbursement strategy for both our RVU work and for our non-RVU work as well. But don't for a moment think that these are solvable without major changes. So I want to give you some examples now for a second. Let's talk about a trillion. So what's a trillion? 1,000,000 seconds is about 11.5 days. 1,000,000,000 seconds is 32 years. And 1,000,000,000,000 seconds is 32,000 years. A stack of $1 trillion bills would reach a quarter of the way to the moon. And if you had spent $1 million a day from the day Jesus was born, you wouldn't have spent $1 trillion yet. So that's a $100 bill. That's what 100 $100 bills look like. $10,000. $1 million. $100 million. These are in $100 bill denominations. That's $1 billion. That is $1 trillion. And this is what our current U.S. deficit looks like in terms of $100 bills. Federal budget, the current deficit is a little over $15.7 trillion and rising. The national budget is $3.6 trillion. Remember, trillion dollars. Remember what it looks like. The $1.2 trillion increase in the debt ceiling in 2011 will trigger across-the-board cuts, the sequestration of spending equally split between security and non-security programs. The across-the-board cuts will apply to mandatory and discretionary spending in 2013 to 2021. And although there are exemptions, Medicare providers are not in the exemptions. So we are not exempted. Medicare patients won't pay any more. We are in part of the sequestration unless something happens. This is what federal spending looks like. Big hunk is Medicare and Medicaid, a lot is interest. This is what our tax receipts look like, where the money comes in. You can see we spend 3.5 trillion, we bring in 2.3 trillion, we borrow the rest. Where does that money come from? There's only a couple of sources, and it's individual income tax, some Social Security taxes, and a little bit of corporate taxes. There's not much room for increasing the money to pay all that's needed. So this is what the federal budget looks like. I draw your attention to the lower part here, and those big numbers are the Treasury, that's the debt, the Department of Defense, Health and Human Services, and the Social Security Administration. That's the federal budget. If you went back, if I can go back, there's not much else. So when you're looking at making cuts, there's only a couple places that it can come from. So what do we spend on health care? This is the total health care expenditures per capita in 2009, and it's gone a bit up in 2011. I didn't have a slide for that. But it's about $8,000 per person per capita. We are by far the most expensive nation in the world for health care in terms of per capita expenditures. The average from the OECD is about $3,200. It's true if you look at it as part of the GDP. What is our component of GDP? And it's about 17%. That may not be too much, but it's clearly out of whack with the rest of the world. And if you look at this, the top one is growth in hospital, hospital inpatients, and then below is physicians. But the trajectory from 2000 to 2009, and it really hasn't changed at all, continues to go up. So what do we get for what we spend? We do pretty well in some areas. For cancer survival, breast cancer, under Chart 4, colorectal cancer, we're kind of right at the top. We do a lot better. What don't we do so well at? And that's complex disease care, which we should be able to. So these are admission rates for asthma on my left and diabetes on my right, but it's also the same for COPD and a number of other complex medical conditions. We don't do well. Bigger numbers here are worse than smaller numbers. Look at infant mortality. The other red bar is Canada. We do a little better than Chile, Turkey, and Mexico. These are complex. This isn't necessarily what we spend on healthcare. There's a lot of socio and things that go into this as well. But we don't do well in this measure either. And patients care about it. This was a Gallup poll last year. 58% were worried about health care to a great degree, 25 for a fair amount, and only 17 were not worried at all. How do we do in terms of what we do less of? We're actually pretty good in some areas. We have less practicing physicians. It shows you we're 23rd, 26th, 23rd. We have fewer physician consultations, fewer acute hospital beds, fewer hospital discharges, shorter lengths of stay. We actually do pretty well. What did we do more of? Not surprisingly, it is procedures and it is imaging. We are leading the world in that regard. So what do we spend on imaging? I'm not going to talk about necessarily dollars, but we spend a lot. This is from 2006. It shows from the Massachusetts Blue Cross data the growth in MR and CT from 86 to 2006. And there's good reason to do that. Again, I'm not going to get into that. You don't see exploratory laparotomies anymore. You have answers before the patient gets operated on. We do all sorts of wonderful things. Our technological innovation and updates have caused significant capital expense. Product cycle length has decreased. we have pretty high valuation for imaging procedures, and the utilization rate outpaces services and growth in almost all other areas, and I'll show you that. This is from the Group Health Cooperative in Seattle, looking at expenses per enrollee from 97 to 2006. So it's about a 100% increase in 10 years in the cost of imaging for that health plan. That's about 7.2% a year compounded, is that right? It's a lot. And it gets worse. Because if you look at where the imaging happens, it happens more in the older populations, and that's all of us moving into that direction. The baby boom bulge is moving in that direction, and so there will be more requirements for imaging than there are now. There'll be more costs for imaging than there are now. This shows it in another way. The purple is imaging, the orange is tests, and this is growth rate. And imaging and all testing go up more than anything else, and imaging beats out testing pretty much. This is from MedPAC. MedPAC, by the way, is not a friend of radiology. MedPAC is more a friend for primary care. Not that that's right or wrong, but it's very important to understand that. And so you look at aggregate growth in Medicare spending per beneficiary from 99 to 2004, all physician services grew at about 31%, imaging 62%. Total Medicare expenditures for imaging services paid under the physician fee schedule, 2000 to 2006. All imaging in the bold line. In the heavily dashed line is advanced imaging, CT, MR, and nuclear medicine, PET, and all other imaging is relatively flat. The growth rate continues to go up. So who are they looking at? It's us. Don't make any mistake about it. We are in the bullseye. We continue to show reasonably good salaries. We don't seem to be able to control utilization. Part of that is not under our control. Over half of imaging studies are interpreted by non-radiologists, so there's a lot of self-referral going on in there as well, but we're the target. So what I showed you before was up to 2006, 2007. The DRA came in, and those of you that are running independent testing facilities know what that meant to you, but it caused a dramatic drop in spending. It's now flattened out, but there was a big drop, and it tended to flatten the curve of the growth. Another way to look at that, this is trends in Medicare spending for imaging, and it is in percentage growth. And what you can see in the light blue is that the DRA came in and the growth dropped dramatically. It has started to go up again because it has to go up, because we provide good services, because we have an aging population, because we provide good information. But the growth in the other things, in testing and other procedures, continue to rise dramatically. That doesn't mean we're out of the bullseye. A couple of other things. These just came out 2 days ago. Pulled them out. The USPSTF had said that PSAs aren't recommended, right? It's just part of a trend of doing less testing. New York Times said experts say reducing wasteful tests could help preserve Medicare and Medicaid. The ACR, as well as other things, came out with a whole series of things that probably shouldn't be done. Antibiotics for sinus infections initially. Imaging of back pain before 6 weeks. All the things that we know that are good, but this is being picked up. What's happening with private insurance policies? The RAND survey showed a 14% drop in healthcare spending for families enrolled in high deductible health plans, with a decrease of usage even in the free preventative services. And healthcare reform may be headed to mostly catastrophic coverage policies. So on the left are all workers who are in a greater than $1,000 deductible plan, and from 2008 to 2011, it went from about 18% to 31%. And for small business workers, it went from 33% almost to 50%. And I just saw some data that came out today that high deductible plans have gone up 18% in the last year, from 11.4 million patients to 13.5 million patients. Is imaging growth an outlier? Well, based on the assumptions that all segments of healthcare costs should grow at an equal rate, we probably are. But is that a fair way to look at us? I don't think so. It equates accelerated growth with inappropriate growth. I don't think so. It ignores the natural evolution of technology as a driver of improved health care. Suresh told you that. This is true. It ignores the cost savings incurred as increased use of imaging replaces other more costly methods of diagnosis and treatment. This is true. And it is an inaccurate perception fostered by a dearth of studies that prove what is intuitively obvious to all of us, that we make a major difference in the care of our patients. We are going to need to start proving that. So I will quickly go over the history of healthcare legislation because it's kind of fun and I always like to do history type things. Something I didn't know. Oops, let me go back again. Earliest healthcare proposal was in 1854 to set up a benefit for indigent insane, which would also help the blind and the deaf and those who can't speak, through federal land grants. The bill passed both houses of Congress but was vetoed by President Franklin Pierce. For those of you that remember Franklin, he probably vetoed the first healthcare proposal. And Pierce argued that the federal government should not commit itself to social welfare, which he believed was properly the responsibility of the states. Sound familiar? With the Great Depression, more and more people couldn't afford health care, and Franklin Roosevelt, in the initial Social Security legislation, included publicly funded health care programs. The American Medical Association, as well as state and local affiliates, fought it as compulsory health insurance. Roosevelt finally removed it from health care provisions, and it was the fear of organized medicine, the opposition to universal health care, that was a standard for decades to come. After World War II, Harry Truman started the Fair Deal, or tried to do the Fair Deal, which called for universal health care as part of that. It failed miserably. But in 1946, the National Mental Health Act was passed, as was the Hill-Burton Act that built a lot of the hospitals back in the 50s and early 60s. And in 1951, the IRS declared group premiums paid by employers as tax deductible, and there went what happened in third-party payers. In the early 60s and into the 70s, public opinion shifted towards the problem of the uninsured, especially the elderly. And since care for the elderly would affect everyone eventually, supporters were able to avoid the worst fears of socialized medicine. So after Lyndon Johnson became president in 1964, the stage was set for Medicare and Medicaid. And this is what the more recent things look like. There was the Social Security Act of 1965, EMTALA, the Emergency Medical Treatment and Active Labor Act in '86, the HIPAA laws in '96, Medicare Prescription Drug in 2003, and Patient Safety and Quality Improvement Act in 2005. In March of 2010, Congress passed PPACA, the Patient Protection and Affordability Care Act. And I'll talk a little bit about that. Only Democrats. There were no Republican supporters whatsoever. It was very controversial. Bill proponents felt that it was the answer to chronic problems. Bill opponents thought that it encroached on individual liberties and interfered with the doctor-patient relationship and was far too costly. And the CBO estimated that PPACA was going to cost about $1 trillion between 2012 and 2021. The primary goal was to increase patient access to health care, so there'll be 32 million more uninsured who will gain coverage as a result of the law. That still leaves 20 million Americans without coverage, unfortunately. It takes care of health insurance reform. It implements innovative coordinated care models. but it imposes policies to help control the rising cost of health care. Key components: young adults were able to stay on their parents' policies through age 26. Uninsured for at least 6 months who were denied coverage due to pre-existing conditions could now get insurance. There were tax credits for small businesses. It eliminated lifetime bans on insurance coverage. And new health plans had to offer preventative and screening services at no cost to patients. There was an individual mandate that by 2014, residents must have health insurance or be subject to payment penalties. The very poor were exempted from this. There's a component for health insurance exchanges where they're state controlled, and by the way, Michigan just decided not to go ahead with this for the time being. Some other states have. There's the Independent Payment Advisory Board, the IPAB. It's a 15-member board. They are unelected, they are bureaucratic, and they are allowed to make fast-track determinations on Medicare physician reimbursement. It's kind of like the base closing. If you know what the base closing commission is like, they vote on which bases to close, and then they send it to Congress, and Congress doesn't get to pick it apart. They get to vote it up or down. And this is the same thing. They'll make decisions, and Congress, which does not have a spine, will not vote it down. So it is totally outside of the political realm, which is good and bad, and it will do things that Congress won't do. It takes away health policy from the U.S. Congress, and all U.S. physician groups are united in opposition to this. There's Medicare expansion, as I talked about. Also in that is the review of misvalued codes. So it's based on those that are fastest growing and new technologies so that the secretary can make adjustments. Guess which is the fastest growing? Guess which has new technologies? It is one of the rationalizations for the MPPR, the professional component. I'll talk about that. And the technical MPPR was also expanded in PPACA. The PPACA also established the Medicare Shared Savings Program to promote accountability. It allowed groups of providers to form ACOs. That didn't go over initially. And there were pioneer ACOs that got a little better. They revised the ACO rules, so there is more acceptance of that. And there are a variety of bundled payment initiatives that are being looked at. The ACOs could include hospitals, physicians, group practices, and they are to begin pretty soon, and some have already been awarded. The Secretary was to develop national voluntary bundle payments in 5-year pilots, and that has already started as well, or at least chosen. Medicare and Medicaid Innovation Group is there to look at new ways to reduce expenditures. One way is the incentive payment for referring physicians to use appropriateness criteria when ordering advanced imaging studies. Now what's going to happen really is that the Supreme Court will make a judgment on the underlying constitution of the entire law, and I'll talk about what the college's vision of what that might look like later on in the talk. So in summary, it's historic, it's sweeping, it provides insurance coverage for a lot of Americans that don't have it. It is going to be costly. It's projected to have a deficit reduction over 10 years of $130 billion, but $1.2 trillion over the next 20 years. Paid for by a combination of reduced Medicare spending and selective increased taxation. Decreased Medicare spending is going to be to the providers, to the hospitals. Projected to decrease revenues to imaging by at least $3.5 billion over the next 10 years. And don't forget what I told you before, we've already seen a $6 billion hit since 2007, and it's not over yet. And radiology is the only physician specialty in this law targeted for specific cuts. The law may violate the Constitution, and we'll find that out. Let me talk a little bit about the college. This is what our college looks like. We have our members, 35,000 strong. We have several thousand volunteers. We have our council. The ACR staff is about 450, 500. and the Board of Chancellors and the Council Steering Committee, and our 5 pillars. We'll talk about advocacy first. So our college's government relation and advocacy departments serve as the voice of our specialty in Washington, and it's very important. So in 2011, continued to work on very thorny issues facing radiology, economically motivated self-referral, continued assault by CMS on both the technical and professional components, physician practice information survey reform, because there are problems with that, the U.S. Preventative Service Task Force, who's also had problems and needs reform, radiation safety and care legislation, and Medicare coverage for CT colonography. Our college's major effort was to garner congressional support to block CMS from implementing Medicare's recommendation to inappropriately reduce our professional payment through the MPPR, the Multiple Procedure Payment Reduction. It is a totally flawed concept. And with support from legislators and regulatory efforts with CMS, we were successful. The college was successful in reducing the cuts from 50% to 25%, but the college cannot stop there. We've been working with the House and Senate to get enough support to pass legislation requiring CMS to block continued implementation of the MPPR. We need to get passage of House Bill 3269, the Diagnostic Imaging Services Protection Act, which now has about 243 co-sponsors. And Senators Ben Cardin of Maryland and David Vittner from Louisiana have just introduced a companion legislation in the Senate. We've been active in the area of health information technology, giving important input into meaningful use criteria, especially for radiologists, and electronic health record incentive programs, for image sharing, for quality metrics, for the radiation dose registry, and appropriateness criteria guided clinical decision support. We've worked with FDA, the NIH, the NRC, the White House Office of Science and Technology, and the Agency for Healthcare Research and Quality. We've worked on state issues as well, the radiology assistant, appropriateness utilization of imaging in Maryland, and working with many states on dense breast legislation and radiation reporting legislation, just to name a few. Our advocacy efforts are essential to assist the government relations work. Foremost in this is RADPAC, and I'll go into a lot of detail a little bit. It had a record year in 2011. We raised over $1.4 million from just under 3,200 contributors. There's the Imaging Saves Lives campaign. It's our advocacy effort and involves letting the public know who we are and what we do, letting them know that we are their doctors. And there's a grassroots program going on. We've helped organize 20 site visits where members of Congress toured radiology department to really see what we do and how we positively aid in the care of our patients. We had Hanson Clark come to Henry Ford. He sat for a long time, watched how we read studies, was impressed that, in fact, there is not a reduction when you're reading an abdomen or a pelvis or the abdomen and pelvis together. He understood it. He went back and co-sponsored that legislation. We need to have more of that. We really need to have them understand what we're doing. Economics is another important part. It's often used for our congressional work as well. As I said, one of the biggest things was the MPPR. We published this article in the ACR. It was an analysis that refuted the efficiencies that the GAO, MedPAC, and CMS believe occur when multiple studies are interpreted together. The college meets regularly with MedPAC and CMS officials. We interact with CMS on HOPS APCs and correct coding initiatives, including medically unlikely edits. We have strong presence in the AMA CPT editorial panel, and we develop a number of CPT advisory opinions with our work through the AMA. We evaluate and attempt to influence the data and methodology used for the practice expense values in the Medicare fee schedule, which we have not done as well as we need to over the last couple of years, and we continue to express our concerns with the flawed data through the Physician Practice Information Survey. We represent radiology on the RUC, which advises CMS on appropriate RVUs for all physician services. We present data to the RUC for evaluating new or revised services. However, in the past several years, we've had to defend existing values, and that's caused a great deal of difficulty for our physician volunteers and for our college staff. We've worked with the Brookings Institution, as well as the AMA and other specialties in developing alternative physician payment models. We commented on the initial ACO rules as they related to radiologists and what we do in patient care. And our Future Trends Committee is charged to look at health policy concepts that may affect radiology's future and make recommendations to how the college should act. We have a new committee, the Imaging Policy and Economics Research Committee, where they'll begin to look at data to show imaging's value in the healthcare enterprise. Quick overview. I'm going to go through this very quickly. There was a power shift in the midterm election in 2010. As you all know, the split Congress made it difficult to pass any legislation. It was basically gridlock. Addressing the federal debt with the establishment of the congressional debt ceiling dominated a lot of last year. And in fact, because it failed, it increased deadlock. This year, it's going to be even worse with the congressional campaigns that are coming up. Much of the activity in the House was driven by Republican leadership. They repealed the PPACA. It obviously didn't pass the Senate. But as an interim, they're going to try to defund as much of PPACA as they can. And with debt ceiling negotiations, as I said, ruined, there is whatever little bipartisan spirit went away. The IPAB, as I said, is a real problem. There was a bill passed, the H.R. 5 Protecting Access to Health Care Act, repealing it. It passed the House. It will not pass the Senate. The SGR fix. There's been an extension for 10 months. And if it isn't fixed, we're looking at a 32% cut in conversion fee. Things that are very, very important to us, not that any of the things I've talked about isn't. It's avoiding the arbitrary cuts to our professional component, the work we really do. And so I talked a bit about this. MedPAC recommendation 2 was to combine services and reduce discounts when it was done on the same day. It was initially supposed to be 50%, and we got it down to 25. But it expanded the policy to include different physicians in the same practice. So if you happen to be a subspecialty group and you did a head, neck, chest, abdomen, and pelvis, and the neuro folks did the head and neck, and another group did the chest, abdomen, and pelvis, it was going to apply to that as well. But that was stopped. As I told you, Pete Olson and Betty McCollum submitted the 3269 House bill, and we now have about 243 co-sponsors. That's excellent. And it would block the MPPR in 2012, and it mandates transparent study and process in years ahead. The Senate bill, again, does not have a lot of co-sponsors yet. It was just introduced in early April, and it's a companion bill. We're also worried about arbitrary cuts to the technical component. Equipment utilization rate is one of them. As you know, they tried to increase the utilization rate or decrease our reimbursement as part of the pay-for and the trade adjustment program with Korea, and that got stopped. But there's a number of other things. The imposition of the Medicare prior authorization program, which is still up in the air but may really happen. Like I say, no cuts were included in the trade legislation, but it was very difficult. Self-referral. MedPAC continues to avoid recommending the closing of the in-office exemption loophole. There's going to be a GAO study this year, and hopefully if we can prove that there's a lot of money to be saved, maybe they'll look at it again. Sustainable growth rate. We had the 1-year extension, as I said, but we're looking at a 32% cut, and it isn't clear where that's going to go. One of the recommendations, let me go back for a second, one of the recommendations from MedPAC was to cut specialty reimbursements by 16% and keep primary care flat as part of the solution to the sustainable growth rate. In summary, for the first time since 2006, last year, there were no cuts to diagnostic imaging in federal legislation. That's because the college worked very hard and partnered with the right groups to have that accomplished. ACR advocacy efforts helped thwart attempts by the federal government to impose $1.3 billion in diagnostic imaging reimbursement cuts. We continue to fight misguided attempts by MedPAC and CMS and Congress to cut our professional reimbursement. And here's an advertisement. Josh Cooper is our Senior Director of the Federal Government Relations. Changes to the Medicare fee schedule, again, going back, I cannot emphasize enough, and I'll let you read this, how important stopping this MPPR is. The hits keep coming. So it's going to apply to the professional component to 119 CPT codes, including some that have already happened with the current technical component reductions. CMS is soliciting comments on the following expanded MPR policies that will appear in future rulemaking. Applying MPPR to the technical component of all imaging services. Applying the MPPR to the PC of all diagnostic services furnished during the same encounter. So a patient comes in for a CT of the abdomen and pelvis and needs an ultrasound of the lower extremities. The MPPR will be employed. To the technical component of all diagnostic services. CMS states that the payment reductions resulting from the expansion of the MPPR to the PC will result in a savings of about $50 million. And this doesn't save the government any money, it just gets redistributed to the rest of the physician fee schedule. It's a statutory requirement. And they believe it'll be an impact to radiology of only approximately 3%. But that's not necessarily true depending on what happens in the future. There are potentially misvalued services under the physician fee schedule. So here's some of them. An effort to ensure Medicare is paying accurately for physician services. This year the focus was on high volume and dollar codes to determine whether these codes are overvalued. A mandate for a validated process. The PPAC specifies that the Secretary shall establish a formal process to validate relative value units under the physician fee schedule for misvalued codes. Consolidating the reviews of potentially misvalued services starting in 2012 and going forward. There'll be a formal 5-year review of both the work and the professional expense with annual reviews of potentially misvalued codes. And they'll have a public nomination process where the public can nominate potentially misvalued codes. And it won't be the individual Jane or Joe on the street. But they'll be able to submit codes with supporting documentation. Bundle coding. So we've already seen a number of bundle codes that occurred. Those that occur greater than 70%, 75% of the time will be considered for possible bundling, and this is what happened in 2012. No one's sure, but these are what looks like might be on the docket for 2013. New payment models. The ACO. So our ACR Future Trends Committee has developed a draft model. Proposed rule is out, we've commented on it. There's hospital bundling models, there's capitation models, there's episode of care models that are out there. And we're trying to do guidelines for radiologists and how they can fit into these various models, how they can contribute, how they can do contract negotiations, how the models might cross over, data and studies to validate our positions. Accountable care organizations established the Medicare Shared Savings Program. This is an ACO definition, and I'm not going to go into that. Radiologists have to be involved in the front end. We need to be involved in decision support, CPOE. We have to be the consultants showing our value in non-RVU work. We already have a CMS demo project. We're one of the conveners at Henry Ford, and there are others that are trying to show that with appropriate decision support, we can reduce the utilization or the use of inappropriate imaging, which may get away of pre-authorization. We hope that will work. We've done the rescue trial as part of the ACR, which showed the value of coronary CTA. Radiologists act as radiation safety officers with respect to ensuring proper equipment calibration, along with medical physicists, and proper training for technologists, and proper dosing of radiation for patients. Radiologists have to be more involved in the governance structure. Everyone here should try to be on their hospital boards, be team leaders and ACOs. That's the only way we'll have any chance at all. Much of this will be done locally, and there's only one way to do that. Radiologists have to be more active in managing all radiology services and service lines to be more efficient and effective in patient care. We have to advocate for quality measures with incentives for radiology. For example, perhaps 2% of their salary would be based on contributing to lower mortality rates or reducing length of stay for hospitals. Those are all possibilities. We need to continue to demonstrate the value of imaging to the healthcare systems. Educational and legislative efforts to develop value-based parameters will be very important. We have to closely monitor ACOs as they develop. When there's an accountable care organization, you have to have various roles as radiologists that can play in the ACO, and evaluate an integrated service model with guidance for members on how to be part of cost savings and to share in those bonuses. The college will continue to defend the fee-for-service payment system. It won't happen overnight. It will take time, but it definitely will be happening. We need to assure that radiologists and radiology are prepared for the future. And the college is working in many ways to do just that. This is a presentation from Cindy Moran, and I'm going to kind of read it verbatim. Cindy is in charge of our legislation. She is a very knowledgeable individual. So she talks about no one can predict the future. True. But she's going to, in this next several slides, we'll talk about what she thinks might happen, 3 scenarios. Supreme Court decision could affect all of the scenarios, and oral arguments have been done. We'll know next month, hopefully, what's going to happen. And so what could the Supreme Court do? They can uphold the individual mandate and therefore all of PPACA. They can rule the individual mandate unconstitutional and unseverable, and therefore the whole law goes down. They can only abolish the individual mandate and the rest will stay intact. Impact on insurance industry makes this unlikely. And the Medicaid expansion rule, they could do that as unconstitutional, and the rest may remain. So it's not clear what's going to happen. Regardless of the ruling, the House Republicans could replace PPACA or allow states to fill in the breach. Repeal and replace legislation could contain TC cuts and or prior authorizations, because we've already seen that. But this could be the vehicle where we get our legislation, H.R. 3269 and the Senate bill, introduced. We will not have enough support to do this as an independent piece of legislation. We're going to have to tie this MPPR thing into some other ongoing legislation. And they're already working on this. And this shows you what could happen, and I'm not going to have you look at that. So, scenario 1, the Supreme Court rules PPACA unconstitutional. So in response to the Supreme Court, House will develop a bill providing Medicare catastrophic coverage for all patients. Very basic insurance, no mandates, cost of legislation covered by additional Social Security payroll tax. This is just what she thinks might happen in scenario 1. Riding the momentum of a decision of the Supreme Court, the bill passes the House and manages to get enough Senate votes. If the Supreme Court declares the law unconstitutional, thousands of newly hired CMS employees are suddenly unemployed, and the political implication of such an event is really unknown. Continuing on scenario 1, if it's deemed unconstitutional, the Secretary's authority to go after mispriced services may still happen. There'll be a change in the equipment utilization assumption rate. CMS wanted to go from 50 to 90. Congress and PPACA went from 90 to 75. It may well go back up to 90% for the equipment utilization assumptions. Changes to the Tech MPPR and the scope of policy. Congress and PPACA went from 25% to 50%, and CMS applied to non-congruous body parts across all modalities. May happen. Self-referral disclosure language, gone. One of the little things we got in the law to stop self-referral. No cost sharing for preventive services, like mammography, gone. Continuing on scenario one, the Independent Payment Advisory Board is gone. Yeah, that may be okay for us. Centers for Medicare and Medicaid Innovation and Decision Support could be eliminated, but the Secretary has previous authority to create demo projects anyway. All taxes from drug and device companies, gone. Insurance reform, pre-existing conditions. Children's coverage in patients' insurance policies until they're 26, gone. Grants for state-paid medical malpractice reform, gone. Physician sunshine disclosure requirements, gone. Scenario two, November, December post-election lame duck. So a lame duck session defines the remaining months of the 112th Congress. How active the lame duck will be depends on the Supreme Court and the outcome of the election. It could be a substantive lame duck or a lame duck. If it's substantial, the Tea Party swan song or Senate Democratic swan song. So all physicians facing a 32 Medicare cut due to the SGR. The sequestration in January 2013, the mandatory 1.2 trillion spending cuts may or may not happen. This will include provider cuts, of course. Multiple expiring tax provision, debt ceiling still on the horizon. A highly emotional, volatile period, and everything could be on the table. And radiologists are vulnerable to all kinds of cuts. So if this happens, we will push hard for HR 3269 into some broad legislative package and fight those cuts. If it's a lame duck, control of the House, Senate, or White House is shifted and lawmakers decide only to pass a series of short-term things to get us into next year and the next Congress. Change in the makeup of the Congress ruins a slim chance of making any substantial policy decisions at the end of 2012. If it's a lame duck, Congress will pass a short-term, maybe 2-month SGR extension again. They'll pass a short-term extension on the current Bush tax cuts. Lawmakers will pass temporary 2-month sequestration delays, and lawmakers will pass temporary 2-month debt ceiling laws, maybe. If they do, we are again vulnerable to cuts. Scenario 3, either Barack Obama is elected to the second term or Mitt Romney to a first term. Policymakers will wait until 2013 and the 113th Congress to legislate. Chances for entitlement reform are real. Debate will continue to focus on significant changes to Medicare due to the doubling of beneficiaries and the insolvency that's on the horizon. If Romney is elected and the Supreme Court upholds health care reform, could administratively repeal PPACA and rein in health care spending through entitlement reform. Who knows what will happen to the sustainable growth rate? Medicare premium support, Medicaid block grants, state-based insurance reform, greater patient responsibility for health care costs. And again, if you're looking at someone who has a $1,000 deductible or a $4,000 deductible, as we're seeing even in this state, you don't think they're going to ask, why are you getting this test? Do I really need to see that primary care doctor? Yeah, my back hurts, but I don't know if I want to spend $1,000 on an MR. All providers are vulnerable to cuts. If Obama is reelected and PPACA is retained, they'll be continued to push for greater coordination of care. On the SGR, Obama pursues MedPAC strategy of freezing payments for primary care doctors for 10 years and lowering specialty payments for 3 years. May happen. Increase in patient cost sharing. probably going to happen no matter what. It's right now happening, as I showed you, in private insurances. It's almost certainly going to happen in somewhere or another in the federal government. Pete Packard crashes due to the Supreme Court ruling. He picks himself up, dusts himself off, and starts all over again. So depending on the Supreme Court and the outcome of the election, we could witness any combination of the scenarios. ACR remains nimble and prepared to deal with each of the scenarios, but it will be a very, very challenging next 6 months, and then it goes on into next year as well. RadPac and grassroots, I'll go through this very quickly. We did pretty well in the 29 to 2010 thing. We've got in $2.3 million in hard money. In 2011, we had a goal of 1.25 million. We collected 1.459 million, so that was good. The goal was 3,000 contributors. We had 3,162 contributors. Is that good? I don't know why every radiologist, and I'll say this again a little later on, in this country doesn't contribute in some form to RadPac. I don't know why every radiologist in this state doesn't contribute to our state PAC. It is what allows us to talk to the legislators. We don't buy them, but they will listen to us. Very, very important. So we had top honors, a lot of states did very well. Here are the states that met the 20% contributor participation goal. Gosh, where are we? We're certainly not in that group, unfortunately. Electoral landscape, I'm not going to go into that. We did have 428 fundraisers in 2011, events in Washington. We contributed to federal candidates. I think that's all been very good. We hosted more than 20 fundraisers. The college does a very good job in this regard. We have, again, RadPac organized 21 facility visits. There is a new grassroots program. It was initially called RAG. It's now called RAN. They changed Radiology Advocacy Network instead of group. I think RAN is a much nicer name. Is to increase participation with calls to action. So previously there was no assigned committees, there was no lack of formal reporting structure, variable responses in 2009, when the utilization rate was up, we asked everyone to call their Congress representatives, or their senators in this case. Of our entire membership of 41,000 people, 650 people called, 2%. We did better with our call for the MPPR. We had over 7,000 people call. That's a 19% response rate. Wake up. This is cutting your professional work, reimbursement, each and every one of you in this room. If we don't get this passed, why wouldn't everybody call their congressman? Why wouldn't everybody write a letter or send an email? It isn't hard to do. Why only 19%? It boggles my mind. It's so unacceptable. It's your pocketbook. Forget about health care, care for our patients. Look at it selfishly. Why didn't we call? I have no idea. We have to do better. We have to do better. So we're trying to identify individuals, trying to find hosts for facility visits, on and on. I won't go into the structure. I'm running kind of late, sorry. Advocacy is very important. Vermont, they had a 21% payment reduction proposed in 2012 on top of a 25% reduction for the same codes in 2011. Coordinated effort, 50% of the radiologists in the state sent letters. They rescinded the law. We need to develop advocacy networks within the chapters. We need to do that even here in Michigan. Find a good way to get the message out to our people, make it easy for them to respond. Cut through this. So the college really needs all radiologists, all interventional radiologists, all radiation oncologists, all nuclear medicine physicians and medical physicists to become members. We need grassroots efforts to support critical issues such as writing Congress. We need our members to support our advocacy mission by contributing to RADPAC and our Michigan PAC. And we need to actively participate or get participation by our diverse members. So we're all members. We need to get our colleagues to join the college as well. And the challenge is really to become active. And the college is the only U.S. radiology organization capable of standing as a strong protector at the doors of the House of Radiology. We are the only ones. Thank you.